Okay, we are recording this. Hey, Ashley, if you get any requests saying to be let in, I'm trying to kind of monitor the waiting room as well and letting people in kind of as it pops up, but sometimes it doesn't pop up when I screen share. So just
Okay.
wanted to give you a quick heads up. Welcome everybody to our weight loss presentation. I'm trying to grab this. Here we go. There we go. Now it's pretty. How's everybody doing? Thumbs up. Hi, Kara. Hi, Tiffany. This is so exciting that we get to do this. This is something that I know a lot of y'all have been asking for a very long time, is that you have the ability to start prescribing weight loss. We all have patients that want to do these kind of things, and now we have the ability to be able to offer them to not just the select few, but to basically all of our providers. It is also in talks of us allowing the RNs. Obviously, they can't prescribe, but we're trying to find other ways to kind of help integrate them into the weight loss side so they can capture some of those profits as well and try to help grow their business on the weight loss side. It's going to obviously look very different than y'all because y'all are actually prescribing and doing all the telemedicine. So if you do have some nursing friends that work for us, just know that we are trying to kind of work with our legal team to try to figure out a good solution to how we can help implement some type of form of this with them. So let's go ahead and get started. Oh, it did pop up. Okay, so for today, what we're going to be going over, we're going to talk about how the GLPs, basically how they work, what they are. We're going to go over the mechanism of action for it. We're going to talk about when it's approved, when it's not approved, and also really just kind of talk about how we should be prescribing this medicine. It is a wonderful drug, but at the end of the day, kind of the best way that I like to describe it, it is a band-aid on a gunshot wound. We really do have to start talking to our patients about how this is not just you take a magic pill or you take a magic injection and all of your dreams are going to come true. You do have to do some nutritional work, and you also have to do the physical work in the gym as well, getting moving, start exercising more. And those are the types of things that we also need to be talking to our patients about. Obviously, we're not personal trainers and we are definitely not nutritionists, but we can talk to our patients about making healthy food choices. And know also in the background, we're working on some additional things to see if we can try to implement some of those things for our patients as well. We're also going to talk about who is a candidate and who is not a candidate for these drugs. And then obviously understanding the contraindications and the potential side effects, and obviously the safety of these drugs and what we need to be talking our patients about. And then Ashley and I have some tips and tricks for prescribing, and then go through the aesthetic record of how you chart. There's a video that I did a screen recording so you can see exactly how to do that. Ashley?
Okay. All right. So for some of you that already may be doing this in the clinics that you work in, this is going to be a little bit of a review. So just bear with us. For anybody that's brand new to prescribing GLPs, this information, we just want you to understand um, exactly what you are prescribing. So GLP, glucagon-like peptide 1. It's an incretin hormone. It's secreted by our intestinal L cells after we eat. So the physiological action, it's going to stimulate your glucose-dependent insulin secretion. It's going to inhibit your glucagon secretion. So all extra sugar being secreted, it's going to stop it from doing that. It slows gastric emptying. So that's why your patients, a lot of people that are on this medication get full quickly after once they start eating. Increases satiety, as I said, and it overall reduces your appetite, secondary to that slowed gastric emptying. All
So
right, so
basically,
you're, oh, sorry.
sorry, go ahead. No, go ahead. You can do it.
The mechanism of action for these medications is it's mimicking our naturally produced GLP-1. So over time, our bodies just because of hormonal imbalance, cortisol, a number of things, we stop producing enough GLP to effectively keep this system in check. So that is what these medications are doing. It's activating our GLP-1 receptors in our pancreas, brain, and GI tract. So since there is a glucose dependent action, there is a reduced risk of hypoglycemia with these medications, which is very different from some of the medicines that we prescribe our diabetic patients. One of their biggest risks is hypoglycemia. As I said before, your weight loss comes from delayed gastric emptying, which in turn suppresses the appetite.
Hey, Ashley, they're kind of being loud in the back. I'm gonna mute myself. Do you mind doing this one?
Yeah.
Okay, sorry.
Okay.
Big group of people came in.
That's okay. So these are our FDA approved GLP-1 receptor agonist as of this year. Everyone's familiar with Ozempic and Wegovy. Ozempic came out for type 2 diabetes and increased cardio. Okay, sorry. And increased cardiovascular risk. Wegovy was the one that was FDA approved semaglutide for obesity. Then, of course, we have Mounjaro and Zepbound, which is tirzepatide. Those were FDA approved for type 2 diabetes and obesity. So the unique thing with tirzepatide, it's a dual GIP GLP-1 receptor agonist. So it blocks out a lot of that food noise for most patients, in addition to the appetite suppression. And all of these are administered as a weekly sub-Q injection.
I will say, so some people may not know what food noise is. Food noise is what a lot of patients will describe where they feel the almost like urge to eat all the time, even though that they just ate. I have a friend who she is on semaglutide, and she said that the food noise substantially decreased. And once she got on the medicine, that she would literally be eating a meal and then she would be thinking about what she's going to be eating next. So it's helping reduce that a little bit more in the tirzepatide than the semaglutide, at least with some of the patients that I'm hearing. Ashley, can you vouch for that as well?
Yes, I mean, I can personally vouch for that. Being on tirzepatide for quite a while, I mean, I almost have no food noise with being on the medication, especially within the first 3 to 4 days of taking the shot.
Yeah.
Almost like
And
I have to remind myself to eat.
yeah. And this is, it is going to be a weekly injection, and it's a self injection. So the patient will be injecting themselves. And we'll go over some of the different areas of where they can inject. And we'll obviously be teaching our patients as well the proper way to inject themselves, just like you would when you do have type 2 diabetics or type 1 diabetics, and you're teaching them how to inject insulin. So very similar to that, like we did in the clinical hospital setting.
All right, so on here, I'm not going to delve into these too much. If anybody is interested in doing some research on their own on the actual clinical evidence that was researched for obesity indications for these medications, we have the STEP trials for semaglutide and the SURMOUNT-1 for tirzepatide. And basically what it showed here is that their weight decreased by 15% on average with semaglutide. That's the max dose, 2.4 milligrams weekly. And then up to 21% with the tirzepatide. So these medications have proven better for weight loss than any of the other medications that they've had out there, like phentermine and what's Qsimia, all of those different medications.
Sorry. And it doesn't have and we'll talk about side effects here in a little bit, but it doesn't have the same side effects as phentermine and some of those other clinics, as far as like the rapid heart rate and things like that, like as much so compared to the phentermine and stuff.
Okay, so indications in patient selection. Um, Obviously, your ideal candidate is going to be anybody that's overweight or obese. Now, this criteria, I'm going to repeat it again in a later slide, but this is also the criteria that we are following in patient selection for prescribing this through My Face Lady. So your patient has to have a BMI greater than 27, between 27 and 29.9, with comorbidities. Now, the comorbidities include high cholesterol, high blood pressure, or type 2 diabetes. They don't have to have all three, they just have to have one if their BMI is within the range of 27 to 29.9. If their BMI is over 30, regardless of comorbidities, then they would qualify as a candidate for this medication. Also, patients that need CV risk reduction. I know of several cardiologists that are prescribing it for heart protection as well. So, the big things to note is that you want to avoid this medication if the patient has a personal or family history of thyroid cancer, or in particular, the medullary thyroid cancer carcinoma type 2. That's a very, very important question for you to ask them in your screening process, because if they do report that, then they are not a candidate. Um, any history of pancreatitis, whether it's alcohol induced or not, you do not prescribe it. And any severe GI disease, such as gastroparesis, we would not prescribe the GLP-1 medications.
Yep. So the reason why with the pancreatitis, so they, I actually had an injector that worked at a different med spa. She was prescribing semaglutide, and the patient actually did have a history of pancreatitis. He ended up he had pancreatitis and he had gallstones as well, like a solid history of it. As soon as he got on the meds, I think it was like 2 months later, he ended up getting pancreatitis, but it was choledocholithiasis induced kind of pancreatitis, and the patient passed. So it's really like now we're getting into things that are not just, hey, we're doing your Botox and your filler. Now we're doing things that can have a significant impact on a patient's risk. So a solid health history is an absolute must with these patients.
All right, so for dosing and titration, you always want to start low and go slow. So with these patients, you will start at the beginning doses, which I have the dosing and formulary spelled out in a later slide. The reason why we do this is so that gives their bodies time to adjust to the medication. One of the biggest complaints with these medications is GI side effects, nausea, vomiting, abdominal pain, and just kind of just a general just feeling kind of blah in terms of the stomach. So when you start slow on a low dose, it gives their body time to acclimate to these changes. So and that I just included an example of the way that they start with semaglutide. Semaglutide's 0.25, 0.51, and so forth.
Also, speaking onto that as well, if you have a patient, so I had a patient the other day who she was on semaglutide and she really wasn't having significant weight loss. And she was on it for quite some time and she was all the way on the max dose of semaglutide. So I decided to switch her to tirzepatide. I have to start back over at the initial dosing for tirzepatide. I can't go from highest dose of semaglutide to the highest dose of a tirzepatide. She has to, since she's starting a whole new medicine, she has to go back down to the base level of tirzepatide and then slowly start to kind of go back up because it is a whole new medicine. So please know that if you do have a patient that you're going to be switching out, that you have to. Oh, I think you're. I'm echoing Lauren on you. Sorry. You have to start over at the base dose again.
All right. So, our most common side effects with any of these medications, obviously, nausea, vomiting, diarrhea, constipation, abdominal pain, or any combination of these. I usually tell my patients that whenever we initiate it or increase the dose, expect to have some nausea. Also expect to have some fatigue associated with this injectable, usually within the first 1 to 2 days after taking it. If they eat something bad, like something high in carbs or sugar, they may have some pretty apparent symptoms of diarrhea as well. So I usually just kind of give them a little bit of anticipatory guidance on what to expect so they're not calling me or texting me thinking that something is wrong. Um, just like we talked about previously in the indications, the less common adverse effects are pancreatitis and gallbladder disease, although these medications can precipitate flares if the patients have a history of it. And just like we said, hypoglycemia is a very, very, very low risk unless they are on these medications in conjunction with insulin or a sulfonylurea. So,
Okay, so as far as the patient education goes, we want to talk about how they can inject the different sites. Kind of think back to whenever we were in nursing school and we were in school and we were talking about kind of, how you divide the stomach up, and you can also do on the hips and the thighs. I have heard, and maybe Ashley or some of the other providers that have prescribed it in the past, that if the patient's having significant nausea, that injecting on the thighs tends to decrease that. Have y'all heard that at all?
yes.
So we want to make sure that we're telling our patients to clean the sites and to rotate them every week. That way they're not having trauma over and over again on the same side. So Heather Hagen just entered. And just giving them the basic techniques of how to minimize pain and discomfort whenever they are injecting themselves with the medication. We also want to be talking about how we need to clean the top prior to taking the needle into the vial to clean the top of that, and sterile technique as much as we can. We want to educate them on the gastric emptying and timing with medications as well. And then obviously going back to talking about the lifestyle changes and about the healthy food choices and getting exercise. The patient that I talked to last week, the advice that I gave her was she doesn't do any type of exercise at all. I told her I want her to start walking for 15 minutes a day. I said, basically, I want you to walk all the way to the end of your street and then kind of come back. And you're going to make a conscious effort every day to get 15 minutes of just straight walking, just so she can start getting moving again. And we can slowly start to kind of talk about introducing additional kind of workout things and healthy food choices. Again, I'm not a personal trainer and I'm not a nutritionist, and I always let my patients know that, but we all know what are healthy lifestyle changes that they can make. They also need to be monitoring their weight and their side effects. I recommend that they start weighing themselves on a weekly basis, and to keep that in their phone. They can put it in their notes section. So it's something that we can talk about at all of their follow-ups.
The other thing too I want to add to that, and I do share this with my patients, is that with semaglutide and tirzepatide specifically, there is a great deal of muscle loss that goes along with the fat loss. Um, and that's well documented and well studied. So it is important to let your patients know that is something that's likely to happen. And that's why we do encourage them to get their bodies moving to try to offset some of that muscle loss. So eating good protein regularly, eating that protein is also going to help improve those GI side effects. So keeping up protein intake and weight bearing exercise will help reduce some of that muscle loss.
Something that every time we talk about protein, something that Shelly used to always say to me was, in order to build muscle, you have to eat muscle. And at first, when she would say it to me, I'd be like, that is disgusting. But you have to eat muscle in order to build muscle. So you have to get protein. So make sure that you're talking to your patients about it. But it sticks in my head, and now I'm very conscious about getting all of my protein in. If it's a protein shake, or if it's actually, meat, or if it's some other type, I'm trying to make a conscious effort to actually eat my protein, which I have found a delicious thing in the morning for anyone who's struggling trying to get their protein in. This is another Shelly tip. We take our coffee and then get you can get like a protein shake. I actually get a coffee protein shake. It's literally from I think it's like core, but it's something core, I think. And they have a coffee flavored one. And I pour it in my coffee and it's like an iced coffee and it's delicious. And I think it has like 30 grams of protein in it. So good. All right, you can talk about NAD, Ashley.
Okay, so NAD, I included it in this presentation because it is something that may be coming soon. We are going to have a meeting with our supervising physicians about this before launching it, but I wanted you to get the education on it um, in the event that it does get launched sooner rather than later. So NAD is a coenzyme that is naturally occurring within our bodies. Its role is in cellular process, energy production, and DNA repair. So I included in this little picture at the bottom the benefits of NAD. So as I said, it's naturally occurring, but just like most things, as we age, our NAD levels naturally decline. And they are further affected by comorbidities like obesity and hypertension. So NAD is almost like it's a protector. So we want to make sure that we are able to restore that so we get all of the benefits of it.
Yep. And again, we're going to be talking to our supervising physicians about this, just to make sure that they are okay with launching it. So this is just the education on it.
It's something that a lot of providers are pairing with their GLP-1 for the added metabolism boost as well. So,
yeah.
Now, these on this slide, this includes some contraindications, and I'm going to expand on them. Some of them are more caution versus a contraindication, specifically with blood pressure medicines or insulin. So, obviously, if anybody has an allergy to it, they can't have it. Just like any of the products and services that we offer to our patients, we're not going to give it to them if they've had an allergy to it in the past. If they have cancer, we're not going to give them that. Any severe renal or hepatic impairment, it has been advised against. If they have the medullary endocrine carcinoma type 2, just like the GLP, we would not give them NAD. Bleeding disorders, mental health conditions such as bipolar and schizophrenia, they have warned against that, and as well as your patients taking blood thinners. Now, if they are on a blood pressure medication or insulin, it is said that NAD also can decrease your blood pressure and decrease your blood sugar naturally. Mm-hmm. So it can compound the effects of the medications they are on. So you want to just give them this information so they're aware that it can lower their blood pressure or blood sugar more, especially if they're on medications to control this. Of course, if they're pregnant or breastfeeding, just like everything that we do, we're not giving pregnant women or breastfeeding women this medication. And people with heavy alcohol consumption, we're not going to prescribe it. So I know that seems like quite a lengthy list, and it kind of leaves us to most of our healthy patients that are just overweight. Okay, so this is our weight management protocol and standard operating procedure for prescribing these medications. I actually have it in a formal document, and I included the link at the bottom. Anne can post this, or I can post this to the Facebook page so y'all can go back and re-refer to any of the information, and you can click that link to actually see the SOP. So this is going to be available to all of our APCs starting out. You are going to chart this in AR just like you chart any of the procedures you do for your patients. The only difference is it is documented as a health procedure versus a cosmetic procedure. As we discussed before, your criteria is overweight or obese patients. If they have a BMI greater than 27, to 29.9, they must have a comorbidity of either hypertension, high cholesterol, or type 2 diabetes. If their BMI is over 30, they qualify for the medication, regardless of the presence of comorbidities. If they are below 27, they do not qualify. So we just have to tell them that. And oftentimes, if we're getting through the MFL line, Shelly does a really good job of trying to screen some of those patients too, collecting that information. And if they're below 27, she'll let them know that we will not prescribe for them. If it is people that you know within your circle, you will just have to let them know that. Like we talked about before, exclusion criteria, history of pancreatitis, thyroid cancer, or MEN2. And that also includes if they have a family history of the thyroid cancer or MEN2. In aesthetic record, we have pre-templated our notes for semaglutide and tirzepatide. Just like the neurotoxin and filler notes, they're pre-templated as a dot phrase. The one thing that you need to do every time you see your patient is that you need to document their height, weight, and BMI. When they do their initial intake, that is where the medical history part gets documented. So these visits will be done via telemedicine. Telemedicine can be done straight through aesthetic record, or you can also create a Doxy link to give to your patient and use the Doxy link. If you use aesthetic record, it will actually transcribe your visit and import it into the note. So there is it doesn't, because it's like speak text, it's not always 100% clear, but it's pretty good at spelling out what the conversation was during your visit with them. They will have medical history forms, consents that will all be completed in aesthetic record. And as I said, we have the weight management dot phrase templates for your notes. So once you finish your visit, you will get payment for these visits, just like you do when you do Botox or any of our services. You will collect payment through aesthetic record before you send the prescription.
So this is, am I muted? No. Okay, so this is our new pharmacy that we're going to be using. We were using Empower, and they were taking about 3 to 4 weeks or so to get our patients their medications. Hill Country Pharmacy, I sent the prescription on Thursday, and he responded immediately, said, got it. We'll send it out on Friday. The patient had it on Monday. So significantly faster. The pharmacist is very nice and very easy to work with. It is a very simple form that you can actually automatically input. And I have the form here. Let's see if I can pull this so y'all can see it. So this is what the form will look like when you download it to your computer. And so that way you can simply go ahead and you can automatically put these things in, and then you can save it to your computer and then email it over to the pharmacy. And we have the email and all that stuff for you. So very simple procedure to do. Let me go back. Ashley, do you have anything else to add to it?
Yes, I know. Yeah, I know it's a little bit different than e-scribing. There's a little bit more effort to it. But you can pre-fill that form with your information, as the prescriber. And then all you will need to do is click the boxes for the actual prescription and fill in the patient demographic information. When I spoke to the pharmacist about this, I asked him about it, and he said that they have worked very hard to work out all the kinks, and the way that they have designed the form will avoid the pharmacy from having to contact you or contact MFL about any questions about the prescription. So I think that that will be helpful. When we were using Empower, even with our built-in e-scribe that we thought was foolproof, the pharmacy was still forgetting to send the patient. Some patients were getting shorted a vial. There was just a whole lot of issues with it, which is what prompted us to kind of seek services elsewhere. But yes, Lauren, to answer your question, we will email this out to everybody. Um, so they will have a copy to save to their computer. Um,
Yeah.
for the Texas prescribers, this is going to be billed to clinic and shipped to patient. There is an option for that on the form. So make sure that you pre-fill it to bill to clinic and ship to your patient.
This is what she's talking about
If
right up
you
here.
are
So billing to physician and then ship to patient. That's exactly what she's talking about right there.
while you're stay on the form for a second. While
Oh,
you're on
sorry.
the form, I'm also going to point out another thing that they need to have is that you must select something for clinical necessity. So, as we know, there's been a lot of issues with some of these medicines since they were removed from the shortage list from the FDA. So, one of the workarounds is that there's some sort of clinical necessity for why we need a compounded GLP. So, history of vitamin deficiency, or if you need a multi-dose vial, which is what they're going to be given, select either one of those. I would not select twice weekly dosing because we're not doing that on any of our patients. But either history of nausea or vomiting, vitamin deficiency, or multi-dose vial, I don't really think it matters which one you select, but you have to select one. Okay. All right. Yeah, go back. No, go back to the other one. The pharmacy one. Okay. Um, for my
Oh, which one? This one?
yeah,
Okay, sorry.
for the Louisiana prescribers. So the pharmacist that I'm working with, he is licensed in Louisiana. The pharmacy, however, is not yet credentialed in Louisiana. Our workaround for that is he can provide those prescriptions for our Louisiana patients, but we are going to do a little bit something a little bit different on our form than what Texas is going to do. For Louisiana, you are going to bill to the clinic and ship to the clinic. I will provide all of you with the clinic address that you need to include on there. What the pharmacist is going to do is he is going to put all of those prescriptions together and send one shipment to the clinic. Stephanie is going to receive that shipment and send it to your patients in Louisiana, just like she does when she sends you product and supplies that you order. This is going to be a temporary band-aid for us until the pharmacy gets credentialed in Louisiana. So, it shouldn't really be any extra stress for you as a prescriber unless you don't ship to clinic. So, just be mindful of that. When we fast forward, you will see the pricing sheet, and I will send that out in an email as well with the pharmacy or the prescription sheet. But the way that the compensation will work is for every weight management televisit that you do, it's going to be $50 that you get as the provider. And you will do every 30-day follow-up visits with your patients.
Yeah, so that's different than what we've done in the past. It was they were getting a 3-month supply. So this is a way for us this was kind of twofold. So we can kind of monitor the patients a little bit closer to make sure that their medicine is being uh, being received, and it's also they're having positive impact on it, and so that we can monitor them from a clinical standpoint, but then also from a financial standpoint for y'all can capitalize on doing that telemedicine monthly as well. So they will only be getting a monthly dose. So you will be doing a telemedicine with them once a month. But again, that will help your paycheck because you get paid $50 every time.
Okay. All right. Then over here on this slide on the left hand side, I have included the price list. Like I said, I'll attach it to the email as well. We are not distributing these out just like our MFL price list, but you can use this as a reference in quoting your patients for this. The pricing compared to what it was with the previous pharmacy, the pricing is much, much better than previous. Tirzepatide, no matter which way you spin it, um, uh, I don't know how some pharmacies are charging less than what I have on here, but my research has shown that we are pretty comparable to what all of the pharmacies are charging now. The price that you see on the right hand side includes your $50 telemedicine visit fee. So when you go over this with the patient, that's what you can tell them. I have included it down in the bottom that the pricing is all inclusive. It includes your telemedicine visit and a couple of other things. They'll be shipped all of the medication and supplies to their door. There is no charge for shipping to the patient. And then they will have monthly assessment and consultation visits with you every 30 days. So I kind of put those in a little bulleted list at the bottom for just things for you to remember to share with your patients. This is the formulary on the more middle to right hand side for this specific pharmacy. As you can tell, the milligrams are a little bit different than what you see with Wegovy or what you see with Mounjaro or Tirzepatide. This is the formulary that the pharmacy has come up with the B12 compound and everything in there. So the dosing is close, but a little bit slightly different than those other medications.
So this is that
All right,
full form. Sorry, go ahead.
Mm-hmm. No, that's all I was going to say.
Yep. Yeah, this is the full form. Again, whenever I went ahead and I sent to this all, I went ahead and I like pre-populated all of my information in there, my signature, my MPI. That way I didn't have to do it every single time. And then I can just input the patient's information and select what I want to do, save it in the email. It took literally 30 seconds. It was super easy. And then he emailed me back saying, got it. We'll send it out tomorrow morning. All right, so that is it. I'm going to
now I did
you.
on that thank you slide. Sorry, Anne, didn't mean to cut you off. There is a little bit of a quiz that I and an attestation that it's a Google form that I want y'all to go through. This is just part of our continuing education. This is just to show that we educated you on this before we launched this as a service. That's important from a medical legal standpoint for us. We want to make sure that we're all covered as providers. So if you want to move forward with offering this to patients, you will need to complete that little quiz Google form, and I will send that also in on the Facebook page so y'all can quick access it.
Okay, this is how you are going to be charting this in aesthetic record. Okay, so whenever you open up AR, this is the test account. So you can see, we're gonna go through exactly what we did with this. So you're gonna hit health instead of cosmetic. And then you're gonna click new consultation, weight management. And then next, that chief complaint is gonna be obesity. And then I just put some random notes in here about what the patient wanted to lose as far as weight wise. And then I can put my note in here as well.
Yes, this is where the dot phrase will come in. And there is an initial note for tirzepatide and semaglutide, and there is a follow-up note for those. Um, the follow-up note specifically says the patient is denying any side effects and goes into that more specifically. You can free text in these notes anything that you want to edit or change or you feel that needs to be documented. You can free text, but this kind of covers most of what you would need to document.
And that patient is, I put 29, their BMI is actually over that. And this is just the test dose. But if they are under that 30, you do need to add the comorbidity to make them qualify. Ashley, do you want to answer the question from Ashley as far as the cutoff date to switch over
The
from
for
Empower?
Empower. So all of this is going to be active August 1st.
I was kind of the test provider this past month.
Yes, because I had to revamp everything in aesthetic record in here to make this as easy as possible for everyone. So Anne was my guinea pig to make sure that she could find everything. And remember that your patients will need a telemedicine consent as well. All right, I'm trying to catch up on the chat. Let me see. Okay, Julia, no, there's no need to order labs on the patients.
No. And then as far as weaning off, Ashley, do you want to kind of talk about the weaning off
Yes.
conversation?
So this is kind of a tough one to have because a lot of patients are so happy with where they are. And even if on their own they are a couple of days late on a dose, they notice the difference of how they feel in terms of inflammation and water weight. So they'll put on a couple of pounds, and they're going to notice that. So if they actually do get down to a BMI that is lower than 27, what I am finding many people are doing is slowly weaning them to half the max dose that they were on. So if they reached that goal on the, let's just say the 10.8 milligrams of tirzepatide, then you are going to wean them down, go down to the next dose, which is what, 8.1, and then at 5.4, to let their bodies adjust to that. I would never suggest stopping them abruptly because they reached a BMI of lower than 27 because they have to be able to learn how to maintain. They are going to have a little bit of weight gain associated with cutting back on the medicine. So I think it's important to let them know that, but that also goes into a little bit of our exercise discussion and our nutrition discussion with them. So typically we will get them down to about half of what their max dose was.
Did that answer your question, Katrina? And Lauren's been and Katie have been prescribing it with us for a while. Lauren, do you have any additional feedback or insights on that?
No, I actually have weaned off a couple of patients who reached their BMI, and I pretty much did it like that. And both of them have come off and been off for at least 6 months to a year now, and they've maintained the weight loss. So I basically just did it really slow, and I backed down, like I just basically walked backwards, every 4 weeks, and then left them on like the lowest dose. And once I got to the bottom, I did like, okay, we'll inject every other week. And then I just kind of stretched it until eventually they weren't taking it anymore and they had like fully adjusted. But it does take time. And I always, like when I'm doing the initial consultation, that's one of the things I go over is like, if you're not in it for like the long run, because it's one thing to like take take it long enough to lose the weight, but you also have to get off of it correctly, or it's all just going to come right back. And so it's just part of the consultation, and I've had pretty good success with it so far. So
Yeah. Does anyone else that's on this call currently prescribe it? Have any other pearls for new providers that are going to be prescribing this?
My advice, I I prescribe in family practice, but if they have any type of procedure coming up where they'll be under anesthesia, they need to make sure that they tell the anesthesiologist or the surgeon that, because it can cause aspiration because their stomach contents do stay longer.
Good point. The slowed gastric emptying.
I have a question. I currently prescribe them in my family practice, and so usually what I do is when I start them on the medication, I send them Zofran for their nausea. Is that something that we're able to do through here or no?
Yeah,
There
you can.
you can call it into their pharmacy. I there's no functionality like a form or anything, but you can just send Zofran and document it in your note.
I will say I just got a new app on my phone. It is fantastic and it's free. It's called Docu Update. And Kyler has an ear infection right now. And so I was able to basically send over an e-script for amoxicillin for his ear infection. So super simple just for that. So if you wanted another choice outside of, calling in like the simple things. Obviously, we're not allowed to prescribe any type of, pain, anything at all. It has to really kind of stick to, the weight loss meds, Valtrax, Zofran, and antibiotics just kind of as needed for specifically for our, if we have a patient that has an infection related to aesthetics. Not like, hey, I have pneumonia. Can you prescribe me something? It has to be specifically related to us doing a procedure that caused an infection. But so there's a great app.
So we would send the prescription to the specialty pharmacy or their local pharmacy?
Their local pharmacy.
Walgreens, CVS,
Okay.
something like that near their home.
Is there a separate charge if you're calling in something like Zofran for them through My Face Lady?
No, that's just out of the goodness of your heart.
You got it.
Yeah. Docu update, Katie. It looks like this. I'll find it.
I prescribe quite a bit of it.
You see it? It's the purple one. Docu update.
I prescribe quite a bit of it, and there's like 5 things that I just reinforce over and over and over again. And I call it just the 5 pillars of success for them. And one is protein. Goal is between 90 and 120 grams of protein, clean protein per day. 2 is a good probiotic and fiber supplement for GI support. 3 is a significant amount of water intake because we want the body to stay wet and squishy. 4 is at least 4 meals a day, which is hard for a lot of them, but to help maintain a good protein and their metabolism, I'm like, you're going to have 4 meals a day. They're going to be bird size. It's 4 meals a day. And then 5 is functional and plyometric exercising. So I agree with the 15 minutes of walking, but I really try to have them like alternate doing weights with 2 cans of Chunky Campbell's soup on the couch while they're watching TV or something, just to help maintain that stabilization.
Yeah. And we're definitely looking at maybe bringing on some type of like nutritionalist and a personal trainer that can do some counseling for our patients as a benefit as well. So that's something that we're working on the back end, because again, really at the end of the day, this is a kind of a gunshot on a Band-Aid on a gunshot wound. And we have to teach our patients how to live a healthy lifestyle, because they've kind of gotten into this routine, this unhealthy routine, and we have to help them break it. So,
I also set up realistic expectations because patients with underlying metabolic or hormonal dysfunction like PCOS, metabolic syndrome, or undiagnosed insulin resistant, I just make sure that they are fully aware that they're not going to have a substantial weight loss for at least 3 to 5 months, especially the PCOSers. And so what they see on social media, you guys touched on it earlier, but what they see on social media is this great rapid weight loss. And that's just not the case for patients with underlying metabolic dysfunction. So making sure they're aware going forward about this.
Yep.
Yeah, and your PCOSers, because that used to be me, they take an enormous amount of um, dietary modifications. Like they will not be successful if they do not change their lifestyle and diet.
Yeah. And we're going to be having some more kind of education stuff coming out about this and some more resources that we can kind of give y'all to help you be successful. So this is, as we're opening up to all of the providers, we're going to be providing you with some additional support with that. So. All right, well, we'll go ahead and wrap this up. This call was recorded, so we'll make sure that we get it posted to the Facebook page. I will post it probably tomorrow morning. And again, this is going to launch August 1st. And if you have any questions, Ashley and I will kind of be your go-to person for any questions, and we are always here to help you. We will be creating an additional WhatsApp group for providers who are prescribing weight loss. And for new patients that are wanting to get on, it is going to be the exact same kind of protocol we do for new patients that call in for neurotoxin. Shelly will call in and, Shelly will go in on that group and say, I have a new weight loss patient. So obviously it doesn't matter zip code now. And it's going to be first come, first serve. And you can't individually text Shelly. It has to be on that app that you respond first. So first come, first serve. And then obviously you will have your own patients that you can see as well, your family and friends, and you can market yourselves. But for new patients, that's what it's going to look like. And then you will essentially take over from there. Okay. So it's not going to be this back and forth anymore. She's going to say, I have a new patient. You're going to say, great. And you will contact the patient after that.
Right. And I am working on, I know you have heard from me this week about getting your NPI numbers. I'm working on wrapping that up so I can get all that in the pharmacy so they can get that inputted so you are a recognized prescriber on their end. So that should be good to go by the 1st. I will update y'all and give you the green light as soon as the pharmacy confirms that for me.
All right.
Natalia, yes, they are.
I would love that email, Hagen. Yes, if you could share that, and then I'll get with Heather as well about the 5 pillars and put something together. Thank you so much for sharing that, Heather. That's a great pearl and a great resource for everyone to have.
Yeah, I love that. I love
that. Is especially pharmacy reliable? Yes, very, very much so. Yeah. Okay. All right, guys. Well, we will, like I said, I'll post this tomorrow morning and we'll launch this officially August 1st. We'll create the WhatsApp group probably over the next couple of days and it'll go live in August. All right. If you have any questions, we are always here to help you. We hope you have a wonderful rest of your evening. Talk to you guys later.
Thanks. Good night.
Good night.
Good night.